basically is what mass casualty incidents and it's just some beautiful addition. So this is going to be our objectives. So we hope that by the time we finish, we'll be able to understand the concepts, understand some of the triage systems that we use. Then we'll explain the color code and also apply it in both admin and pediatric situations. So MCI, according to the video, is everything that you guys have said. Plus the fact that the cases have overwhelmed your resources. The resources can be human, can be consumables, can be machines, they can even be space, can be your building. So the incident is such that it has overwhelmed your resources. That is what we call a mass casualty incident. So it is actually irrespective of the number of victims. They can be one, they can be two. But in case we brought a patient who has severed a very major artery and is bleeding profusely. Don't have items to arrest that inflammation. He has become an MCI.
Yes, please, your voice is low. How can I make the voice come?
An MCI from one part.
It's on live.
And not
The voice
MCI
is
from
low.
an MCI for women. And not an MCI Yes. That's why I realize that sometimes in places you come to the emergency and then either you see us ringing the bell or we come to the door, we shouting for them. They can feel that maybe the injuries as well as us. So when it happens like that, we need to triage. Let's say they come and they are alone. We need to do what we call the greatest route for the greatest number of people. So we need to sort them out quickly. And then put aside those who, quote unquote, will delay and concentrate on those who have better chances of survival. These are for them. So let's look at it. We have different triage systems that we need to sort out mass casualties. In a general emergency, we in Ghana, we use the South African triage. That one is not START. That's what we use in Ghana. There are other triage systems that are not yet also. But in Ghana, we use the START. Then, when it comes to disaster or mass casualty, we have various types. They are all acronyms. We have MCATs, we have START, we have START, we have JumpSTART. They are all today. I'll just introduce MCAT briefly. But we concentrate on Jump and START and JumpSTART. That's what we'll be using. After the training, we have an simulation example involving the ambulance. And if possible, we find some. We will concentrate on using START and JumpSTART. And after that, we do a quick primary survey, also with an acronym called Dr. ABC. So when you are using MCAT, you are basically concentrating on responsiveness, whether the patient is alert, is responding to noise, responding to pain, and all that. And you are checking for bleeding. Is the patient spontaneous? Or is the patient needs to be assisted before they can do some airway maneuvers, or the patient is breathing normally? And then you also look at the pulse and also the capillary rhythm. Then there's severe bleeding. We look at that with uncontrolled. Talking about capillary rhythm, what is the normal refill time? 3 seconds. 3 seconds. So it should be less than 3 seconds. And how do you check it? Yeah, that's
Pressing
so you press on a little bit, and because you know it's less than 3 seconds, you are counting. And 1, and 2, and 3. Then you release your hand. When you release your hand, the shoe flow will into or like this before 3 seconds. So you press, you count, when you release, you continue counting. So it's like this. And 1, and 2, and 3, and 4, and 5 in your head. So by the time you finish saying your 5, you should have flown. Then you know that it's simple. 3 seconds. So when you use the M card also, you categorize your people as red, yellow, green, and black. This is the addition. In START, we don't have black. Okay, and we have orange. But here we have red, yellow, green, and black. Red is victims with life-threatening conditions, and they need urgent care. Yellow, they are serious diabetes. You can delay the treatment of it. You can hold on to them, hold and attend to them. Then the green are minor injuries. Usually, how you get the green is that when you have a lot of cases, someone stands somewhere and shouts that there is having medications there. I have a lot of pain medications here, so everybody come here for it. Somebody stands somewhere and shouts like that. All those who are able to walk to you are all automatically bringing. Anybody who is able to walk, regardless of what the issue is, the arm might be hanging like this, but he's able to walk. All walking wounded are green cases. Okay, then we can now concentrate on the rest. Then the experts for the black are people who are already dead or have injuries that are incompatible with life. Like, there is no way any manipulation will bring them back. Maybe somebody is having an open chest or you can see obvious depression like there's some lung confusion or sometimes even a cardiac confusion. There is no way the person will do that. Not a bad thing. So those people, unfortunately, you don't touch them. And that's, of course, the resources and your time allows you to concentrate. I remember there was a time in Tamale, this accelerator track packed with a lot of rooms and human beings and an accident around the apparatus. Usually when the things happen like that, those who meet them, they just pack everything. Throw this one, throw this one. They brought them to the emergency like that. There was some way. Some people still have some way they have to leave. And then you will the next thing, because the idea is that you can do everything waste your time, but then you will be. Why don't you concentrate on those who believe? Last, and bring this information. So let's concentrate now on what we will be adopting as our MCI, triage system. So we have START and we have JumpSTART. In fact, we don't know why they added jump to it, but the only thing is that JumpSTART is for kids, and then START is for adults. And then that one concentrates on doing things, respiration, perfusion, and mental status. Respiration, perfusion, and mental status. So usually we have this acronym. Someone will say, oh, RPM, the other will say 30 can do. So it's like RPM 30 can do, RPM 30 can do. What that means is that for respiration, for adults, you are looking at 30 seconds, that's your seconds. For perfusion, you are looking at 2 seconds. And then the mental status is what the patient can do. The patient is going to obey commands. Okay. So obey for respiration, there's no respiration, there's no breathing. You can open the airway. If you open the airway and there's still no breathing, that patient is black. You don't move to another person. Okay. And then I think justice, former emergency. What are some of these? So we have various every documents. I don't want to bring them, so I can but we can still look at it. So we have job trust, we have team leads, we have medicine, they can pay everything. But there are specific, if the patient has a cervical injury, they are not going to affect the system. So the medicine, you are suspected everything that might have affected the head. What's the head like? Just build the shoulder. That's what we call shoulder. That's what we call build the shoulder like then your chin is like this. And then your head is down. So if you do any of these functions and still the patient is not breathing, that's black. If there's respiration and it's more than 30, the person is hyperventilating, the person is dying, is breathing by is very, very fast. That is a rare case. And that one is determined. Maybe there's something that I can avoid you, there's something of my behavior, just take it down for the person. Okay. So for respiration, if you are not breathing, and they do airway management, you are still not breathing, you are black. Okay? But if you have respiration, and your breath count is more than 30, you are red. So the depends, you look at the so the depends you open the airway, and our patients have to breathe fast. That becomes very nice. These are it for you. Then when you get to the patient, apply rofo. We've talked about that already. You use the radial pulse. If this is, if there's no radial pulse and then the capillary refill is less than 2 seconds, the patient is red. That patient might be in shock.
Okay.
Okay. You are assessing for perfusion. No radial pulse, capillary refill more than 2 seconds. That patient is red. There is a strategy in checking pulse. I don't know if you can remember the values for where and where can we check our pulses? What are some of the pulses that we can may not spontaneously respond to you, but you're able to speak to him, and then he opened his eyes and said, oh, okay, that's it. That's good. Which are you for me? If it's not able to do anything after his red, but if you give a little trigger and the patient responds, that's good. Yellow is that well. Maybe let's give it a few minutes. Let's work the brains out. So let's look at the flow chart. Unfortunately, can we see? We can see. So let's look at the flow chart. Like I said, all working with patients are green. All working. We're going to go the car, some go down and they were able to walk, they are living, or they have their arms. That's a great news. Now, let's start to respiration. If it is present and it's more than 30 minutes, 30 seconds, that's great. If respiration is present and it's more than 30, is great. You need immediate attention. If it is present and in less than 30, then respiration. What do you think is the reason why? If you have a respiration that is less than 30, what's the normal respiration? For adults. So if we have a respiration that is under 30, let's say it's around 20, what does that tell you? It's normal, isn't it? Yes. So maybe your patients may be hemodynamically stable, but don't just complete with that. You need to go through the rest of the day. So then come to perfusion. When you come to perfusion, and then the radial pulse is present, you are good to go. But if the radial pulse is absent, what did we say? Capillary wave. These are you following? Are you sure you are following? Yeah. Any questions so far? If your capillary refill is over 2 seconds, you do what? Control the patient will be waiting, your patient will be short. Remember we saw that earlier. If it's more than 2 seconds, it's supposed to be waiting for less than 3 seconds. So if it's more than that, it's a sign of shock. So you have to control it. If it's under 2 seconds, you are safe, are you not safe? I used to work at the critical sequence, but now it is very, very safe. So if it's under 2 seconds, it is normal. But what is the mental state? You check if the patient can follow from a simple command. Can you open your eyes? Can you raise your palm? Can you sit down? Can you do this? Can you do that? The patient is stable. That becomes a very. What that means is that when you check your respiration, it was normal. When you check your capillary wave flow, it was normal. You came and check mental status, that's the normal. Patient is already normal. That patient will become a delayed case. That patient would have been doing if he walked into the place himself. Is that right?
Yeah.
But when you come to mental status, you ask, and the patient is not able to follow. Even your respiration was fine, capillary flow was fine, it becomes weak. Because mental status is not being followed. What does that mean? There is an infusion, impairment, infusion evidence towards the brain. Okay, that is a cause for alarm. Now let's look at this side of the algorithm. So you check respiration. no chest movement, the open airway, still no chest movement, no sign of respiration. That patient is safe. When the patient is an expert and the partner of the way. If after the open airway, you see some signs of respiration, the patient is doing, you realize that when you have issues with respiration, it's either you are red or you are black. As for respiration, if you confirm the patient is red, just go ahead and intervene quickly. Don't bother yourself with food and apply it. Why? Because respiration usually is the last argument. If you want to be very, very concerned about that. At this moment, any questions?
So the respiration, we count for the 60 seconds. We count for don't divide. And we have 1 minute.
30 seconds. We have 3
minutes.
and they spend 1 minute and they break for that. Is there any other? Because these things become true. You are going to from the way you think you are multiplying by 4. You count for the okay, so let's look at JumpSTART for children under 8 years. Children under 8 years. So if you are 8 and above, you use the adult one. At the children's school, realize that the main differentials are with the respiration rate, also with the adequate, the mental skills. So for reading for children, we are looking at whether the breath is less than 50 or is more than 45. If either of that is right. If it's less than 50, we need to intervene immediately. More than 45, we need to intervene immediately. Okay. Then you can attend to your 5 years old if the patient is happening before time. There's always a consideration for children. For adults, if there is no respiration, you only carry respiration. You don't see it. But for kids, the adult is as good as living with them. So for children, after you maneuver the department, you attend to your rescue works. The 5 years old is nothing. Then you can see the patient is black. Then for the everything skill, for mental skills, use everything. As for the adults, talk to them. See if they can obey. If the children have to go through the day. If you call the patient, you can apply some pain. Then pediatric patients require rapid accessibility to their dynamic physiology. So this is it for all right. Maybe there's no respiration. What do we do? Before we tie catheter, we do what we call rescue breaths. Rescue breaths are either mouth to mouth or mouth to mouth. Do that. Still, the patient is happy. They can tell that she has been if you go through your respiration and it's fine, it is between 15 and 45. Go back for capillary wave. Let's say we get to capillary wave. It is more than 2 seconds. What do you do? Control the patient control. Maybe it's less than 2 seconds, it is fine. And go to mental state. And get to mental state. Use the air. Check whether the patient is allergic to if not, call the child. If you call and it's something, then it is coming to you. Okay. So in summary, any questions? Any questions?
Yeah, the respiration. Okay. If, let's say it's 10 or 8, you start your rescue breath or
So if the respiration is less than 15, you are not doing respiration, you are doing your oxygen concentration. The rescue breaths are what you give. It's like the cardiac respiration is happening. Please, any other?
So, I would like to know what level for the mental status for pediatrics? At what level do you employ the child? Because we have adult boys.
So if a patient is allergic, obviously, that can be there. Apart from that, the responding to words, the responding to pain, or the one responsive, it's just like for adults who obey commands. If you are obeying commands, you are alert, your medical symptoms is happening. But if I have to trigger you for you to do something, or there's a problem, that needs to intervene with you. So it is alert to okay. By responding to points, responding to pain, or unresponsive. That's what. So let's look at a few examples. Let's look at a few examples. We have a building that has collapsed in an urban area. Let's say the open business. You are the first on the scene with minimal supplies. There are 20 victims that have been involved with a variety of injuries, from cuts and fractures to unconsciousness and neck bleeding. You are expected to quickly prioritize care in order to stabilize as many victims as possible. That's always the goal. Your goal is to stabilize or sort out as many victims as possible. So concentrate on those who are victims. Let's look at victim A. So let me just quickly. I hope you can see. So let's look at our victim A. Is unconscious and has no radial pulse. Why do you think this person will fit? Red, yellow, green, or black? You do that with explanation. Unconscious patient, no radial pulse. Always remember. This is MCAT, alright, right? Let's use that. Always remember RPM This perfusion, you're looking at capillary flow, 2 seconds. And then your mental status. Can the patient do this? Can the patient do this? Okay, so let that guide you. How let's see. So this patient is unconscious, has no radial pulse. And then, yes, unconscious and has no radial pulse. Do you want me to put that on the board? I can do that. So that is good. So if that's what I do, the first two, then the rest two. Then we go to so an unconscious patient with no radial pulse, what will you do?
Red. 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 It's unconscious, no mental.
I thought somebody would like that, but that's okay. So let's move on to our next victim. Okay, let me keep that screen. So our next victim is alert that has an open fracture. Our next victim is alert that has an open fracture. If I let me add some other parameters here, his respiration is less than 30. It's less than 30. So respiration is 20 seconds per minute. Capillary flow is 5 seconds. And then it's a rain command.
It wasn't working, right? Basically.
He didn't walk it. He didn't walk it. He didn't walk it. He has a fracture. He has a fracture. So where the fracture is, respiration is 8. Capillary flow is 5 seconds. Who is that? Who is that? Okay.
Yeah.
Because respiration is very natural and the only thing is that after you full time, we expect that we are agree.
Yes.
Who said you?
I believe that it's yellow.
What's the second? What other items?
I think it's red. And from the applying
But the patient is alert too. He obeys commands. But you can delay.
For me, I'll put him at red because I can do my assessment. Because I think that he's alert now, but the capillary flow is telling us that very soon he can become confused or something.
Okay, any other uncle?
yeah, so it's still red.
So it's red.
Yes.
Let's shine. I like the let's shine. Shine. Who the heat? Who the heat? We are waiting fire 5 times. We are firing 5 times. Fire. I like the way we actually brainstormed it. Okay. And I like the rationale and everything. It's actually a very good. avoid. If it is normal, then you can say if the capillary flow is less than 2 volts, you can say it's zero. But because it is high, it intervenes. Okay. Alright, let's look at another.
So please. A question.
Yeah.
So we can always test or triage a red case if within the there's an issue with even one, then it should be a red case.
After respiration, the word will be as an issue. When the respiration is moving, when you get to capillary rhythm, and the flow please, are you following? Okay, let's look at our next patient. This victim walked in with her patient.
Walk in with foundation.
Then another one. Pay attention to this. This is an apneic. Despite airway maneuver or airway, this patient is apneic. Despite airway manipulation.
Red or black?
Red or black? Black.
Red or black? Red or black? It's red or black.
Yeah.
So is it red or is black?
Black. It's black. Yeah.
All those who are for black, let's try.
Black. Oh, maneuver. Despite all maneuver.
Oh, go.
And all those who say it's red. So are we agreeing it's black?
Yes.
Or we are emphasizing?
You take the black.
It's black. Because no respiratory movement. No matter manipulation, so that patient. Okay. The next one is a 3-year-old. Respiration was 10 breaths per minute. And this patient is
Unconscious.
Red.
Yeah.
Have you all tried it?
Red.
Is it red or is it wine?
Yes, better.
It's red, isn't it? Respiration is less than 15. So for them, it's less than 15. More than 15. Then the last one, a 1-year-old.
Let me call you back.
Pulseless and apnea.
Pulseless. Black.
It's black.
What respiration?
Really? So we do everything before we do that.
Yes. And we have to back rescue rate.
So if we do that, it's still
Then go to black.
please, are we all following? Yes. So far, any questions, especially those who joined us later? Any questions? So what we've been doing so far is to triage our patients, assuming that we are overwhelmed with a lot of accident cases or a disaster, a trauma, whatever it is. We are overwhelmed with a lot of patients, and then they come to us like that. We have to find a way of sorting them left. So we reconstituting that thing. And then we should have a way of activating the system. Some places is a building, immediately you get it. So wherever you are, you know that the stroke. So I need to
Rush.
yeah. Some places is like a siren. Even if it's not working, do that the signal for the background. So when they do that, then the team will come and every other person will come. Now, you that have come to help, this is where you come. Immediately the patient comes to ask for ambulance when they come to home. It's as good as maybe they call them that, oh, there's an accident here. And they'll come and bring the victims. Like that. So when they come to you, if the patient comes to you, this is what you start doing. You start assessing the patient from wherever they stand from to see if he's able to walk. If that patient is able to walk to you, take your mind off that patient, look at somebody else, and give that patient somewhere to sit. Because we said what all walking wheelchair patients are great. If you are agreed, you can see within 4 hours. You have that grace period. So you can put that person down, sit down somewhere, and then concentrate on the others. So the other people, somebody has been brought to you, that person is not breathing. Okay, did this, there was nothing. You want the chest, there was nothing. What you do is that you open the airway. Like I said, there are so many ways we can do that. You can either tilt the head, lift the chin, or drop the jaw. And it also depends on the injury of the patient. If there's a head injury, or you suspect a head injury that might affect the C-spine, don't tilt the head. You will better close them. So that one, drop the jaw, is called a jaw drop. That's a way of doing it. And the airway will open. You did that, still, there's no sign of breathing. That patient is black. You call them expectant or safe. Don't waste time with this. But if you do that and the patient starts to breathe, then that becomes what? A red case. At that point, you are looking at what could be causing the apnea that the patient has. Quickly look for it and interview. That is what we do at ABC. Primary survey. After you have sort of go out now. Now you have your red cases or yellow cases. You don't have to use your ABC, your primary survey, or your doctor ABC to look for the things that can kill them quickly and you sort them out. These are your problems. So maybe there's another patient that came. When you check, respiration is fine. These are adults and it's less than 30 cycles per minute. Now, you have to go ahead and look at what? The perfusion by checking the what? Capillary ratio. If you check the capillary ratio and it's less than 3 or it is 2, you are safe. The patient is fine. But if your capillary ratio is more than 2, that patient becomes a red case. Okay? If the capillary ratio is 2, that patient will become what? A yellow case. And get the treatment for it. But if it's more than 2, then there's a possibility that it is bleeding somewhere. Treat for sure. Okay? Now, when you get to mental status and your patient is alert, maybe respiration was fine, capillary ratio is fine, patient is obeying commands, that patient is a green case or a yellow case, and the day is a little bit. But if your respiration is fine, capillary ratio is fine, the mental status is not fine, it's a red case. So any of these parameters, there's a problem there. If any of these parameters has an issue, then you need to interpret the video. That's basically the idea of the START and the JumpSTART. And we said that for children, we do the JumpSTART, and then the differentials are the Sleep is danger. Okay, you have to always ensure that your sleep is safe for both yourself and your patient before you approach. So usually, during hospitals, most people forget these things, and they actually fall them down. If they get a scenario, they have to simulate it out. The first thing you ask is my sleep safe? Maybe it was an electrocution. Maybe they came and told you guys, like the scenario before, you were the first on the scene of an accident. And then there are electrical wires on the floor, open naked wires on the floor. If you are not careful and you rush them, you become then we have to now have additional case. So always ensure your sleep is safe for yourself, your patients, and your bystanders. And then you remove or mitigate hazards. Okay? If it's like an electrical something, you can look for whatever switch, main switches there in the office. If your patient had a pen, okay, if the patient has a pen, maybe he was somebody killed, the person was trying to use petrol to light fire and cook. So if such a case comes to you and the boats are still on, you need to take them off. Okay? If they are burning. So that is such that I mean you might see the scan here and the patient is actually still burning. So in some cases, like the acid burns, your base burns and all that, you need to wash the person down. Maybe it was a chemical spillage. If it's a chemical spillage, you need to send the person somewhere, open the shower, wash it down, cool it down, before you even approach the patient. I remember in confirmation, we had a difference. Let's send them, open the list of the water. Because especially for chemical burns, they keep burning. So that's that for the danger. Make sure you are safe. Make sure your skin is safe. Make sure you are well protected. Okay? So that you don't cause more. Because already we are talking about having less resources. We are talking about doing. So don't come and add yourself to. In fact, there is this law elsewhere that if you see somebody on your way, especially if you are a healthcare professional, maybe you're a nurse, you're on your way to your organ, there was an accident, as a victim, if you use your hands to touch that person, make sure you don't cause more harm. Make sure you are able to keep that patient until help comes. Make sure you take that patient to the necessary or the nearest hospital where that patient will get help. If not, you will find trouble for yourself. So, in simple terms, don't start with what you can't. Don't if the rules are mandatory, if you try it, if you don't have time, maybe on your way, you want to just carry the patient from here, put the patient here and go. You will take your life. You don't start where you come from. That's elsewhere. Oh, that's elsewhere. In Ghana, that one is elsewhere. But you see, the law is a very tricky. This is our law. It's a very tricky. Then you come to R, your response. So these things are from ATLS. ATLS is Advanced Trauma Life Support. It is like ACLS, Advanced Cardiac Life Support. Then you usually do researches and they come out with how we should handle cardiac arrest, traumas, and all that. So these guidelines are actually then the response is that assess consciousness with your aim. You are alert, respond voice, respond to pain, non-responsiveness, and then look for possible purposeful movement or speech, purposeful stress and purposeful movement. It shouldn't be some incoordinated something that is there and you have to be purposeful. Maybe there are some people who put your exact content you want to that's a purposeful movement. Or the patient is gathering, so you want to play something is moving your arm. You are going to be around and those things are purposeful movements. Or speech. I want this and that. Make sure it's purposeful. Now, when you quickly do those things and you go to your airway, so mind you, this is primary summary. This is after you have quickly, like we said, 3 minutes, you are just checking respiration, capillary flow. Now this patient is ready now, and you want to intervene. Okay, so you quickly look at the airway, check for patency, look, listen, and feel. In all the parameters, we look, listen, and we feel. Open, look inside the mouth. Is there anything there? Elderly people who have dentures. Is there any denture that has the blood and is blocking the airway? Maybe there are some secretions like transactions. Maybe in the course of the some metal piece or something went inside it. Something from the car, whatever foreign body is there. Check and see. Is it something you can easily remove? Okay? Then you do that. If there is nothing there, there are no secretions. You can put in some airway agents. You can put some oropharyngeal or nasopharyngeal airway. You can put this inside it to help the patient. Okay. And then the airway management that we spoke about, your head tilt, your chin lift, or your jaw trap. You can do the three actually together. If your patient has no concern, you don't have any concern about some kind of stuff, you can actually do the three. You can lift the head, put the chin lift, put your jaw trap. Then you can consider putting your oral or nasopharyngeal like the same. So usually we use oropharyngeal if the patient is not having a gag reflex. Okay. The patient is unconscious. The patient's gag is not there. Usually when they have the gag, when you put it oropharyngeal, they will bring it out. So if the patient has a gag, maybe you are trying, how do you know your patient's gag reflex is working?
I think when you are trying to insert the oropharyngeal and they are resisting, or there's a new form of breaking it out.
That one, you as if so in that case, you put your nasopharyngeal. The nasopharyngeal is thin. It's like catheter. It's soft and it's malleable. So you can just so it's a beauty like this. That one doesn't go into the truth. Where it will now go and go your vagus nerve and then trigger your gag reflex. So that's airway. So the thing with primary summary is that when you find any problem anywhere, solve it before you move on. Okay. So when you find out that the airway is not patent, maybe if it's suction. If there's nothing and it's a manifest to do it. When you do it, go ahead, check your SPH, check for the patient's breathing pattern, say the accessory whatever problem is there before you intervene, check and see if it's there. If it's not there, then your A is something and you move to your B. Now when it comes to breathing, you are observing the rise and fall of the chest and then the effort the person is using, and also the respiratory rate. You count it again. You look at whether the patient is using accessory movement. Okay. When you are breathing normally, your chest, both left and right, they are supposed to be moving together, okay? And it goes in the cancer. You don't have one part is going up, the other is going down. What we call the paradoxical movement. That's not what the normal is. So if you see something like that, it's a problem. Most of the time, there's a fracture at that side. That is a problem. So when you see that, you need to intervene. If you see that, and then you can't intervene, you quickly call somebody like a senior person who just apply a script. When you do a big population, so you mandate the person like this. When you do a big population, then you do that, go back and look at the rise and fall of the chest. This is also just a quick. Primary survey, we should do it in 5 minutes, sometimes more than that, because when you're interviewing, it takes time. So the idea here is to look for the things that can kill you in like 5 minutes. Those that can kill you if nothing is done within 5 minutes. That is your goal. So those are the things you are sorting out. After this, then there is secondary survey, where there is proper patient assessment. To assess proper planning. You can now come up with like a definite management material. That will take a long time. But here we are only interested in what is killing me now. Let me do that everything. Okay. So when you get to reading and then you look at that, there's a problem and you face it. Most of the problems in reading, especially in trauma, has to do with pneumothoraces and attention pneumothorax. Okay, so those are the things that we do, especially when you are looking at reading. So for the attention pneumothorax, there is a trial for it. Okay, like I said today, that's just clear. Usually, intention pneumothorax is what we call the pneumothorax. When you are someone who can listen to the studies, you realize that where that person is having the tension. So this is it. Pneumothorax, we know that we have the lungs. The tissue is there. We have a cavity. You have the pleural is there, the parietal is there. Okay. There's a lining that is covering the lungs. Then there's another lining that is covering the chest wall. Okay. So in between the lining covering the chest wall and the lining covering the lungs is a space. It's actually a potential space. It's just like a vagina. It's a potential space. It can collapse like this when there is nothing there. You just have some small amount of fluid on the surfactant. That is what allows you to expand and then come back when you are free. Very, very minute fluid, but that allows it to. But naturally, it's collapsed like this. But should anything find its way into that space, like blood, like air, leaking from the lungs into that space, and it happens most of the time in trauma. Maybe there is a puncture, there's a contusion to the lungs. It has torn the lining that is covering the lungs. So blood will now leak from the lungs into that space. Okay? Or air. I mean, our lungs is full of air. Having like some are fractured. And the air will leak from the alveoli into that space. So if it's air, it becomes what? A pneumothorax. If it's blood, it becomes what? A hemothorax. Now, a pneumothorax is air leak into the pleural space, but it is not causing too much of a problem. There's air in your pleural space, but it isn't causing too much of a problem. Most of the times, those ones that are not causing into tension, with some high flow of oxygen at respiration, they go on. So some people naturally have some pneumothorax and they don't know that. But the tension is the one when the air has accumulated in that space to the extent that the pressing on your heart, it's pressing on your trachea, the main windpipe is pressing on it. So it becomes overload. As for that one, you go into a definition of that. Right there in front of your eyes. Okay. So the trials are that you percuss, if you can. You percuss and there's hyper resonance. When you percuss on a normal line, it's called resonance. Okay. This means I keep saying that go on the net, go and listen to videos, listen to the sounds. Try it on each other. Try it on somebody who has a very good
Like.
someone who is complaining of anything, not perfect. Just try it. And you know what the normal sounds like.
Okay.
Put your hand there.
The reason.
Put your hand there. For this your dominant hand. Look for the third finger and get it flexible. And hit it. When you do it well, you get something. This sound is actually called down. This is a down sound. And we have slowing down. Slowing down is the one you do. And then you get something like this. So put your hand on it. Whatever you do is hold it down slowly. When you listen to that from the patient, it tells you this activation. Okay. So go on YouTube, listen to those sounds. And hyper resonance is when you're playing the drum. See how it sounds. That's resonance. So hyper resonance is a higher pitch. Do you know what gives you the resonance? When you're playing the drum, do you know what gives you the sound?
Yeah.
So a drum there is like this and there's one. So it's a lot of things. That's what gives you the sound. So if it's too much, it will be so high pitched. Then your heart sounds will be so distant. You can't hear your heart sounds well. In addition to that, your trachea, everybody feel your trachea. In the middle of your throat. Starts from here, go down. Can you feel it? It feels rough.
Yes.
It goes down. So that is what we call a central trachea. Trachea is central. When there is tension moving to that, it will push it to the other side. So if the tension is there, the pressure will push all the organs to that side. So when you start taking your trachea nice, you won't come here. You won't feel it.
Okay.
You can confirm it on an X-ray, but you don't have to do that. So when you get to your chest, look for those things that can kill you when you are breathing. Your tension pulmonary or your massive pulmonary, those ones they can kill you. And then you look for the signs. When there's hyperresonance, there's a distant heart sound. And then tracheal deviation, please, that is tension in the pulmonary. And then deviation is opposite the tension. So what you do is you pick a needle, a large one needle. You can use gray camera. Okay. Then you look for your fourth intercostal space. Mid-clavicular. So that's why I said, I don't know, maybe another time when we have time. Look at this because it's very important to help all of us, especially in emergencies and these mass casualties. These are the interventions that sustain people. Something very small like this. You're not able to do anything. Something that you can easily do. There's a way of getting your intercostal spaces, counting them to know this is 4, this is 8, and then this is mid-clavicular. Your clavicle divide is imaginary, just like how we divide our abdomen in 9. Okay, you have imaginary lines all over. If you see your clavicle here, mid-clavicular, axilla, mid-axillary, front axillary, front axillary. All those lines. So when you are doing your nasal decompression, go to your 4 to 5 intercostal spaces, mid-clavicular. When you set your immediately the air is immediately you set, you will hear poof. Just like inflating a balloon. And you're like magic.
Wow.
Okay, but again, if you know you can't
Those
finish
that
so that you can't go enough place
Oh.
so when you finish, when you find a problem, and don't forget to check your escape. And then when you finish sorting out your meaning, go back to your page. Go and see that problem that I saw in my face, is this still there? Go and check it. If everything is fine, then continue and go to your six. So it's a relation, your central offices. Look at the rates, the rating and the quality. The last time I said it, that let's not always be concentrating on the pulse of giving us heart rate. In special cases, even if you want to for everything, in special cases, let's palpate it ourselves. Because when you're palpating, you're looking at the character, you're looking at the ring of J, the regularity, the volume. Okay, is it weak? Is it full? There are some pulses that before you say your hand, then they're already hitting you. So you have to look for it. All those things are hiding. If it's short, you are expected to be weak. And then again, you are expected to be fast pulse. And you're reading this. Let's go each other's pulse. Feel somebody next to you. When you feel the pulse, keep it. When you feel it's your finger. Feel the pulse, you tap. Tap, anytime you feel you tap. Oh, how do you feel it? Or you can even feel your own pulse. When you feel you tap, feel you tap. Pay attention to the rhythm. Okay. Are we here? Okay. Please have a follow.
Yes.
Yeah, it gets the rhythm. So you are trying to see whether it's regular or not. Depending on your tap, it becomes like it tells whether it's regular or it's irregular. Okay, that's how it's then at C, hello, please let's come. So at C, that's where you do your hemorrhage control. Put in your large drawer cannula, 2 of them. Which are large drawer cannulas?
The green.
Which are them?
The green one.
the green and the green.
And the green.
The green and the green. If you don't have the green, I don't have the green. Go ahead. 2 large ones over here. Is that running green? Okay, you also assess your screen for color, temperature, and temperature. And you establish an IPO, an IO time interruptions into the rooms. If you have the consumables or the supplies available, you can do an IO. It's perfect because it's very fast. That inside the bone marrow is straight. fully exposed, but after that you have to cover them. After you've exposed and assess the patient, you have to cover the patient to avoid what? Why would you cover your patient, especially in trauma cases, burns, hypothermia, because hypothermia will lead to what? Hypothermia will lead to what will it do to your hemoglobin? Oh yes, agglutination of blood. No one does. That is why, even if possible, give them more food, especially in event cases. They advocate that you need more iron fluids.
How you
If
want?
possible.
How you want?
Some hospitals have drugs. So there are hospitals that have hot and cold water and put them inside the hot water. For some reason, emergency tap goes from, is it 10 or 11? I'm not sure now.
It becomes very hot. Yeah. It's like that.
I can just put a basin and leave the fluid inside the water. Because make sure that your hot temperature is not so these are references. In fact, they are done. These are standard. All that. Our presentation. Finally. So today we looked at START, we looked at JumpSTART, we looked at Dr. ABC. That's our quick primary survey for mass casualties. Now, we will be having a simulation exercise on this. A practical practice is like practical, practicing our hands on the mass casualty, using the START, the JumpSTART, and also the Dr. ABC. The ambulance will be joining us. They were supposed to come here today, but for some reason they were engaged in the program. But they will join us for the simulation. And so they will be assigning groups, especially those of us who are here. We will all automatically
Oh,
can
be the patient.
So what we do is we will, because we are simulating, we have to come up with our patients. Maybe we want to have cases.
I'm the patient too. Shit.
Because there's going to be a video camera. We have to video it for evidence. It's actually a requirement that every year, every hospital should do a simulation. Then, as you guys know, you prepare a review count, you look at things like that. So we have to record it down. So we have to make sure that it's scripted so that we will not fall short. As we're falling short, we are against that. Too much. So, maybe some point where we can when the simulation will take place. Then by then, the list we have, we will see
Like charger.
as for patients, I mean, our able students are getting a lot of patients.
Oh,
So,
we have one in.
they cannot be patient. They cannot be patient because you have to accept it. So, we need people who can make empathy, who can mimic the actions. So, any questions? Any more questions? You have a question?
Okay.
Any more questions?
The battery is low. The battery is very low.
It might go off.
What it will be. So you let me do it next.
Any questions? No? No questions? If no questions, then I'll ask some. So, start. Who can summarize briefly how we go about? So someone will do the start for adults, another will do for pediatric. So how do you do this? Hajia will do for adults. Hajia said her lawyer is sister Grace. So how do you use it? RPM. They can't hear it from the front.
Using the RPM, the R with
Can you hear it?
the R, we talk about our respiration. That when the respiration is above 30, then we will classify the patients as red. If the patient didn't move in, a walk in, will classify as red, and then move to the P, which is the perfusion. So with that, we will check for capillary refill time, and then it should be 0 to 2. It should be 2, but if it's more than 2, if it's 2, we will move to the M to check the mental status of the client. So in checking the mental status, we ask questions. Maybe if the patient is oriented and can talk, then that one, you intervene. If there is anything to intervene, then you intervene. But if the patient doesn't explain, but if the
Really want to go?
oh, it's okay.
Fill out there. Are you done?
Yes.
Let's shine for sister Grace. Shine. Let's get 2 fires. Go. Alright, choose someone to do the pediatric for us. There are a lot of people behind you.
My friend, really.
I'll say as a point that I just be my lawyer.
He was on and off, so I have to go in.
Okay, so with the pediatrics, we are saying that we have to go to the trauma. So with the pediatrics, we with the responsiveness. No, I think with the pediatrics, start with yes, the respiration. So any respiration more than 45 or less than 15 is red. And if there's no respiration at all, and you've exhausted all your manifests, and you code it as black, then you move to the breathing. You check whether the person, the baby is using the accessory muscles, or if there's any confusion in your chest. You have to check out. Then you go to the mental status. You use the A, B, E. The A alert. The B is response to voice. The V is response to voice. The D is pain. Then the U is unresponsive. So when you check all those things, then there's any intervention by you.
First of all, you should. They start with the A.
The bad people are not talking.
Patrick. Share. Airway, breathing, circulation. Breathing, this one here, you know, exposure, you know, say it. Also, that you know, say it. This one here. I did this one here. Chain.
We said that in doing so, or in opening the airway, you make sure your patient is not having any leg or spine issue. If that is so, then you should avoid your head tilt because you might be causing more trauma.
Who will take us to the
Jennifer B, the camera is on you, please. You start.
Jennifer. Rajot. That's how you say it.